Hello and welcome to the Flying Paramedic Podcast. I'm your host, Jeff Poland. So I'd like to begin just by thanking you guys for listening or watching this, depending on which one you're doing. I've been wanting to start something like this for quite a while, and it's really, really exciting. I recently attended the DOS-SMAC conference, and I've been an avid follower of FOAMed and a large number of podcasts and blogs and social media resources for quite a while, and been wanting to do something like this, and figured now's about as good a time as any. So let's start a little bit about me. As I said, my name is Jeff Poland. I'm a certified flight paramedic. Been in EMS for about 4 years. Worked a number of different states, a number of different environments, urban, suburban, rural, and I draw a lot from that experience, as well as some of the experiences that I've had in the military. So obviously the views expressed here are solely my own. My employers, to my knowledge, don't know about this, although I'm sure after this gets published, they will. I work in a small community right now. And anything that I say is solely my own opinion. Any case details will have things change, name, age, gender, and they may or may not come from the area where I'm currently working. I'm not going to mention where that is right now, nor am I going to mention anywhere else that I've worked, but I'm going to draw from experiences all throughout my career in medicine. So I got this idea for the podcast, as I mentioned, after attending DOS-SMAC, and in addition to all of the fabulous resources that were there, fantastic presenters, fantastic people, great community, I met a number of other paramedic delegates, but really, to my knowledge, there were no paramedics presenting. There was no real input on any of the panel discussions from paramedics. We had a fantastic presentation on the future of, pre-hospital trauma management given by a doctor. And while most other countries do tend to have physician-led teams, the U.S. is unique in that we rarely see physicians in the field. So I'm trying to add another voice from a paramedic in the FOAMed community, and really, hope to get us cemented a little bit more as members of the healthcare team, not just people who drive fast and panic. So this podcast is going to be offered in two different forms. We have the audio form, and we also have the video form. Now, the video form is going to be from video taken during some of my flights. I'm a private pilot, currently in the Pacific Northwest, and where I'm at is going to become fairly obvious here shortly. But I'm going to have video shot from the airplane, just kind of as background to give you guys a little something to to look at while you're listening to me. The videos also are going to be available with the air traffic control audio if you guys are interested in that, rather than, just my lovely voice screaming at you for the next 15 or 20 minutes or so. So the background video we have today actually starts off over an area called Elliott Bay, which is just outside of Seattle. We're going to fly down Elliott Bay, do a touch and go at Boeing Field, which is right next to SeaTac, just to the south of the actual downtown Seattle. And then we're going to head on over to the Tacoma Narrows Airport, which is actually where I learned to fly. So with all that background out of the way, let's go ahead and move on to episode 1, which I'm calling Standing By at a Cardiac Arrest. And what we're going to discuss today is our role and our responsibilities to all of the patients in a cardiac arrest scene, or with the cardiac arrest patient who's been brought into the emergency room. So I'm going to open this with a story here. This occurred sometime between 4 weeks and 4 years ago at one of the areas that I was practicing at. I had a student with me at the time. We were dispatched at about 10 o'clock a.m. to a cardiac arrest. We arrived to find a female, probably her mid-40s. She was found down after a night of partying with her daughter. She was last seen with two gentlemen at about 3 o'clock in the morning in the kitchen where she was found when we arrived. She appeared alive and well then, but she was found pulseless and apneic upon our arrival. She was also found with her daughter in hysterics. Now her daughter was in her late teens, early 20s, and just completely distraught. There was a strong smell of alcohol and possibly some other illicit substances on board. So how do you manage this? We're going to go in, we're going to move her out and get her into the area where we have room to work. We're going to start our chest compressions. We're going to intubate. We're going to get her on the monitor. And after we find out that she's in asystole with an unknown downtime, at this point, where are your thoughts? Are your thoughts with the individual that's in cardiac arrest, or are your thoughts with the daughter? Maybe they're with both. What I'm getting at here is how many patients do you really have? In my mind, I've got a patient who I know is probably not going to be viable. And I also have a distraught daughter. I say that now with the benefit of hindsight, but at the time, my thoughts were entirely focused on the individual who was in arrest. And it's really unfortunate because what wound up happening was obviously, very predictable. The patient remained asystolic. A couple of rounds of ACLS were done. It took, I think, about 20 minutes between myself and the medic student to decide that she's not really viable. There's nothing more we can do. But during that time, I had called law enforcement over, and I told law enforcement just to deal with the daughter. Nothing was explained. I didn't involve the daughter at all in the resuscitation. To my knowledge, the only thing that she witnessed was my student declaring a time of death. And I really did a huge disservice to the daughter at that point. My thoughts obviously should be with the individual that's in arrest, but my thoughts also really should be with the family. And there comes a point in every resuscitation where we tend to shift our focus from what can we do to resuscitate to, is the resuscitation going to be futile? And if the resuscitation is futile, how do we inform the family? How do we make that determination? Now, I don't want to talk about when we decide to call an arrest. I don't want to talk about, the merits to working, somebody for 40 minutes versus 20, because that's all very individual. And to be quite fair, Cliff Reed already did a wonderful talk on that I really don't have anything of value to add that he didn't really say. If you've not seen that, I'm going to go ahead and link that in the description for the video, as well as the show notes, and I'd highly suggest that you check that out. So obviously I did a disservice to the daughter at that point, and that's really kind of something that's always stuck with me, and I've kind of vowed from that point forward to do it better. So there are a lot of studies going back to the 80s on exactly, what the role of involving family in cardiac arrest resuscitation and having them witness the arrest is. And there's largely been this fear of having family present during resuscitative efforts. And largely, I strongly feel that feeling is misplaced. I was really only able to find one fairly recent randomized controlled trial, although there's a lot of opinions, there's a lot of case studies, there's a lot of case series out there on it, and I'd highly suggest you to look that up as well. But a good place to start is a 2013 article in the New England Journal of Medicine by, I'm sorry, I'm not French, I'm going to butcher the pronunciation, maybe Jabere, Jabere, et al., where they assess the outcomes of family presence and family involvement during out-of-hospital cardiac arrest. Obviously, this is an area of contention for a lot of people. But what they found was that it was an overwhelmingly positive result. Lower incidence of PTSD and PTSD-like symptoms across a wide spectrum of time after these arrests occurred. Now, the study had a number of limitations, but by and large, everything was positive. Even the people who were just given the choice, that had a demonstrable effect on the family's ability to cope and grieve. Of interest, they noted no real changes in the quality of resuscitation effort, although they did note that they didn't really encounter any difficult patients, any difficult family during their trial, and they suggest that maybe at that point, if a difficult family member is encountered, consider removing them on a case-by-case basis. But largely, they really suggest that family members should at least be given the option to be present during resuscitative efforts. So let's go ahead and let's look at another case here. This case I have is a mid-50s male, estimated downtime of less than 20 minutes with bystander CPR, refractory ventricular fibrillation upon arrival. You find him down in the living room surrounded by his family. The fire department is there. The compressions, as I said, are ongoing. So what do you do? What do you do at this point? You have a potentially viable patient. You have a short downtime. You have good compressions. You throw them on the monitor. You see that they're in VFib. Great. It's a shockable rhythm. It's something you know that, hey, this may be quick. We may be able to get this guy back. So at that point, do you focus on the patient? Do you focus on just, you blow past the 20 family members that are sitting in the room, bawling, hysterical, screaming? You get in there? Do you make sure those compressions are deep? Do you start charging your monitor? You direct somebody to get IV access or IO access, and do you start reaching for your intubation roll? Or do you step back? And do you involve the family from the beginning? Because I'll tell you, a couple of years ago, I would have been, all right, I'm going to rush past. I know what my patient needs, and I'm going to go in there and immediately deliver those potentially critical and life-saving interventions, which is awesome, and that's something we need to be doing. But can we do it while also giving family support? We know that as far as cardiac arrest survival goes, those who present in VTAC or VFib early, who have good bystander CPR and who have good compressions, have the best chance. But that's not overall a very good chance. It goes into the whole, Bayesian reasoning of, what's their prior probability. Simply having a cardiac arrest lowers your chances of survival regardless of the initial presenting rhythm. So why don't we involve the family from the beginning? And something that I always try to do, this particular arrest was one of them, but I always try to go into the scene and at least make sure that the family has been acknowledged. I work in a very resource-limited area, so if I've got a whole bunch of, basic first aiders or first responders and maybe one or two EMTs on scene, maybe I want to make sure that they've actually been given good information to this point. I know that, typically I'm going to be the only paramedic on scene, so I'm going to go in and just briefly, typically while I'm pulling out my IO equipment, while I'm making sure the monitor is being hooked up, while I'm getting my intubation supplies ready, say something very quick, identify who is going to act sort of as my liaison to the family, and often that's a family member. That's usually, in this case, it was the daughter. There was a language barrier, so I recognized, okay, the daughter speaks English. I speak a little bit of Spanish, but her English is much better than my Spanish, so I went up, introduced myself. Hey, my name is Jeff. I'm the team leader. I've got a couple of things right now to do. Give me just a couple of minutes, and I'll be back to fill you in once I know a little bit more. Do you have anything that you need answered right now? I acknowledge them. I acknowledge that they need information. I acknowledge that they want information. And that in return is also going to help me get the information that I need from them when it comes time to gather their history, to think about the underlying causes of arrest and what we can do to mitigate those. So once we've established that therapeutic communication, once we've kind of determined who we're going to talk to with the family, there kind of comes a point where you need to decide, is it better for the team leader to be the one handling all of the communication with the family, or do you have somebody that you trust to delegate to that? Me personally, I generally tend to handle most of the communication with the family. As I mentioned earlier, because of the first case and a couple of other similar ones, I like the therapeutic communication aspect, and I want to make absolutely certain that I'm relaying everything that I can as accurately as I can. But, if you've got another paramedic, if you've got somebody who is going to be able to therapeutically, effectively, and compassionately be able to relate to that family, go ahead and task them to it. But it's very important for the team leader to also acknowledge what's going on and have the opportunity for the family to talk to that team leader. So, all right, it's a fast forward a couple of minutes. You've got your patient intubated. They've got a fantastic end-tidal CO2. They've got an end-tidal of 30 with compressions ongoing. You've shocked them twice. You've given 1 round of lidocaine, and they're still in VFib. At this point, you're still thinking, okay, their end-tidal is great. They've got this good chance. They've got the potential to be a cardiac arrest save. So how do you update them? How do you update the family? And how often do you update the family? We tend to, as providers, be either overly pessimistic or overly optimistic, depending on a number of factors. Very rarely can we actually give them an accurate prognostication. And that's even just for ROSC. We can't accurately begin to talk about neuro outcomes until at least 48 hours post-arrest, and there's a lot of literature on that if you guys are interested in, I'd be happy to get out to you. So how do you give them the updates? How do you, just a real quick, hi there, so-and-so, hi there, Susie. So far, we've given, Mr. Smith 2 rounds of pure adrenaline, 2 doses of pure adrenaline. We've shocked his heart twice, and it's still not beating in the right way. There are still a couple of other things that we can do, and we're not ready to give up quite yet. But, overall, things still aren't looking that great. Are there any questions? And a brief update like that, and continuing, if you haven't gotten pulses back and you haven't gotten a rhythm change, it's important to communicate to them and start setting them up, giving them those bracing terms. We're still trying, but things aren't looking good. Unfortunately, nothing we've tried so far is working. Giving them that realistic expectation and almost cementing it in there. Nobody is going to remember exactly what you've said, and nobody is going to, even in the moment, they're almost going to forget. There's a number of different defense mechanisms when it comes to speaking and taking bad news, unpleasant news, and you really have to work to overcome those. Not because we want to be depressing, but because we don't want to give any sort of false senses of hope. So I generally try to give updates about every 1 to 2 rhythm cycles. So about every 2 to 4 minutes, at least say a little bit of something to the family and explain to them what's going on. A key portion of if you're going to have family in the arrest is somebody has to be explaining to them what is going on. People are going to wonder, well, in ER, they shock and the guy comes back. Why aren't you shocking him? It's important to explain to them in relatable terms. If you go up and you say, you go up and you're sarcastic and say, well, yeah, I could shock asystole, but that'd just kill him. it's not going to be nearly as effective as saying, okay, I understand that that's what they do on TV. However, that it only works for certain conditions. And right now, Mr. Smith's condition doesn't warrant an electrical shock. Instead, what we're doing is X, Y, and Z. Instead, we're giving him this pure adrenaline, trying to get his heart beating. Instead, I've recognized that I think he has a collapsed lung, so we're inserting a needle into his chest so that we can try to get that lung working again. Explaining in very simple terms and avoiding jargon is essential when you're talking about therapeutic communication with families, especially in high risk or high tension situations such as this. So this particular patient actually wound up, we worked for about 20 minutes, shocked around 7 or 8 times, multiple rounds of lidocaine, persistent VFib. I actually got approval to do an intra-arrest catheterization with one of the local facilities. So at this point, we've not necessarily had a change in condition, but as the algorithm was coming towards an end, the patient wasn't. And being able to explain that to the family is also, something that needs to be done, something that needs to be done with practice and with poise. So in this case, Susie, right now we've tried everything that we can do here. Typically, it's better for people if we can get their hearts started outside of the hospital. We can get their hearts started without driving down the road. They tend to do better. We haven't been able to do that, but there's one more procedure that the hospital can do. The hospital that's able to do it is about 35 minutes away. So we're going to go ahead and take Mr. Smith there. On the way, we're going to continue to do absolutely everything that we can, but recognize that this is a last-ditch effort. This is something that may or may not work. If he's going to have any sort of chance at all, this is going to be it. But things, as I said, really don't look good right now. And being able to kind of temper expectations that have been drummed up by the media is absolutely essential. So in this case, that actually had a rather unsatisfying conclusion. It was about 35 minutes to the hospital, and this particular patient wound up going asystolic during transport, and end-tidal dropped down to 12. And unfortunately, despite an intra-arrest catheterization, the patient expired. So that also comes down to, how can we prognosticate? How can we temper our own expectations of the arrest and merge those with the families? How can we meet and find that common ground? If you go up to them and you explain, okay, things are, the heart still isn't beating, but there's still a chance. This number here that I'm looking at, that tells me how all of the machinery in their body, all their organs, it tells me how well they're working. That number is pretty high. That tells me that there's a chance, and we're going to continue to work for that chance. So let's review a little bit. This actually wound up being only a fraction of the material that I wanted to cover, but I'm going to try to keep this under about 27 minutes here. So let's review. In a cardiac arrest situation, you have multiple patients that you really need to be worried about. We need to be focusing on not only the patient who's in arrest, but also the mental health and the well-being of the family and the bystanders, the loved ones of our patients. And we need to be able to do that with therapeutic communication. We need to be able to communicate effectively and realistically with family members. And that can be hard, especially in a resource-limited environment like we find in the pre-hospital world. So what do you guys think? Do you guys have any other suggestions or strategies for mitigating the psychological consequences of cardiac arrest on our patients' families? Do you maybe do it a different way? Do you have any tips or techniques that you'd like me to share in the future? Please feel free to reach out to me, either Facebook or via Twitter. My handle is at JJPFPC. Or, leave me a comment or shoot me an email. I'm happy to respond, and I'd love to hear what you guys thought about this podcast. And I'd like to hear any suggestions for anything you guys might have from here on out. Once again, thank you guys so much for listening, and I'll talk to you later.
We also make that go play after the pass down to town. As soon as they will be returning to the airport for break and landing.
Jack Alpha Mike Echo and Flight Ledger advise turning inbound. Turkey 49 Whiskey, contact ground point 8. Ground point 8.